Just a second. The YouTube live stream is getting started so that even you can watch later on the YouTube. All right, great. Okay, great. Yes. So as we can see, this X-ray is what? You can see all the increased or hyperlucency, we can say. Okay, hyperlucency is there. So what does this gives us the diagnosis of right pneumothorax? Very good, Soumya. Very good, Nidhi. All of you. So please try to be attentive. Today we are going to discuss very interesting things. Okay. So these were the changes which we discussed about this right. Whenever we have the X-ray, we have to check for the right. That is R for rotation. That with the help of clavicle and the spinous process distance, we were getting the idea about this. Okay. Then I is for inspiration. The X-ray should be in the inspiration. If X-ray is not in inspiration, you will not get the proper exposure. Okay, on the lungs basically. Then P is for penetration. You have to see, you have to compare that it's spine visible in excess amount. So normally spine should be just visible through the X-ray film. If it's more visible, that means X-ray is more penetrated. Okay, and if X-ray is under penetrated, then it can mimic pneumonia. And if it's over penetrated, then you can hide the effusion because of that. And last was exposure. So exposure, we have three types of exposure: underexposure, overexposure, and normal exposure. Okay, so when whole chest is visible, that becomes normal. Okay, and normally both angle will be seen. Then we discuss about the ABCDE. A is airway, B is for breathing. We have to look for the lungs and pleura. C is for circulation. We look for the heart and mediastinum. D is for diaphragm, and E is for everything else. Now let's start with the today's discussion. Okay, after that we understood how the X-ray is taken, who are the scientists for the X-rays and all those basic stuff, and we like where what are the different views, where do we take different views. Okay, all this stuff we discussed. What are the two features in the lung, right? So first is horizontal. So right lung has two features, horizontal and oblique fissure, whereas left lung has only one fissure, oblique fissure. And each of that, so right lung is divided into three parts: upper lobe, middle lobe, and lower lobe. Whereas left lung is divided as LUL and LLL, left lower lobe. Never say left middle lobe, okay? Otherwise, people may laugh at you whenever you are presenting any X-ray case or anything like that. Okay, so I hope we are clear over here. Coming to the next part, please mute yourself. Okay, all the participants request to you, please mute yourself. Okay, right. So then we started discussing the X-rays. Shall I think I'll have to mute everybody in second. Otherwise, student might just keep disturbing our. Yes, okay, just a second. Uh, I'm not allowed to unmute you now, and I will mute participants upon entry. Right. Great. Okay, so after that, we were discussing about the certain things, like we discussed lung collapse. Okay, lung abscess. We discussed how the air fluid level were there. Okay, pleural effusion, etc. Empyema was discussed. Okay, then this kind of pneumothorax we discussed. Okay, yes, right. Then hydropneumothorax, that how the air fluid level is there along with the air. So this is the air, and this is the fluid level in the hydropneumothorax. Right? Then what are the X-ray appearance of those in the about the pneumothorax? Okay, that also X-ray, not X-ray, the focus appearance, okay, USG appearance, seashore sign and all will be seen. Okay, then we discuss lung collapse. That what are the different features that you will see in the lung collapse? Okay, right. Then now we came on to the silhouette sign. So what does silhouette means? Silhouette means what? So it's basically two structure that are separated. If there is some air, mass, or some space that is obscurating this margin, this is called as disturbed silhouette, okay, or silhouette sign. So here, let's see. Normally, it should be like this. Okay, normally this border is like this border is like this. But if I have consolidation over here, okay, because of this consolidation, my silhouette is or silhouette border is obscured. Okay, this is called as positive silhouette sign. Similarly, here you can see these are the normal margins of the normal X-ray, right? So these are the few different things where the silhouettes can be obscured, right? Then we discuss about the air bronchogram. Okay, this is the X-ray of consolidation. Then, and what exactly is the air bronchogram? Okay, so air bronchogram means what? Like if this tissue is consolidated, okay, the airway is still intact. Okay, I will just draw airway in different color. Let's say I'm drawing it in a blue color over here. Okay, yeah. So because of this blue airway, you can see the air is passing still through this, which air is what in X-ray? Air is a black or air is a radiolucent. So because of this, the appearance what we get is like this, and this is called as air bronchogram pattern, and it is very classical for the consolidation. Okay, or pneumonia, you can say. Right. So that we saw. Also, somebody asked very good question when we were discussing the heart failure, that when I mentioned that in the early phase, when the pressure is close to 8 to 12, the cephalization occur, right? Upper lobe cephalization occur. So then somebody mentioned ki, how do we differentiate between air bronchogram and cephalization? So as I mentioned, air is a black, okay? And whenever you have any artery or any vessel, that will be radio opaque or white, okay? Or radio opaque, okay? Radio opaque, right? Radio opaque, and this is radio lucent, right? This is the basic difference between two. I hope you understand. Okay. So then we discuss few X-rays, right? Anybody? What do you see in this X-ray? Hmm? Then we discuss classical X-ray. Exactly. Abscess in this part of the lung. Okay. Abscess in this part of the lung. Actually, this was classical for the staphylococcus, right? Staphylococcus. And what does this is called as? This is called as nematocele. Okay. Nematocele, right? Then we discuss something like this. So what does this appearance means? In which pneumonia we can see? This is basically a pneumonia, right? Right lobar, right upper lobar pneumonia. And see this bulging fissure is seen. The fissure is getting pushed. So that was Klebsiella. Very nice. Okay, Klebsiella pneumonia. Okay, very nice. Then, so we discuss about this also. So bilateral fine nodular opacification is seen in the bilateral lower lobes. Okay. So this was moreover the atypical pneumonia. Okay. Like Legionella. Let's say Legionella is a typical pneumonia. Okay. Legionella. Okay, all the routine infections which are caused by streptococcus, staphylococcus, okay, these are, and even Klebsiella, these are the typical pneumonia. And atypical, which is not very common and have the bilateral X-ray features, okay, and are difficult to manage, are your atypical pneumonia. So Klebsiella, Legionella is one atypical, Mycobacterium is one atypical. Also the other like leptospirosis also rarely can cause viral pneumonias. Okay, all these are you can say atypical pneumonias. Then also this was the lung abscess. Okay, very easy one. Now this was something which was a little doubtful for us, right? We can see entire pattern was like this. Moreover, suggestive of yeah, suggestive of Batwing type of idiom. Okay, then we discussed about this. Okay, see the trachea. Trachea is also shifted to the same side. What was this X-ray? See, this trachea is also shifted to that side. Yes, anybody? Yeah, this is aspergillus pneumonia. Okay, this all part is collapsed because of that aspergilloma. Exactly. Okay. Then we discuss this X-ray. What is this sign called as thumb sign? Okay, epiglottitis. Then this tonsillitis, sorry. Then this stipple sign. So this is what stipple is normally, and this is how it appears on the X-ray. The image is not very clear though. So this is called as stipple sign. Okay. Yes. So now, then after that, we discuss about the tuberculosis, how the changes are there, Gons, focus, etc. Okay. Now let's start with the today's discussion. We'll start with the heart failure, and then we'll move on to the abdominal X-rays too. Right. So first is this. See, normal X-ray, normal vessels, how are they? Just have a quick overview on this topic. Normal upper zone vessels are like this, right? Look at these vessels. These are the normal upper zone vessels. Now, if they just start flowing in this direction, okay, I'll just use white color, okay, like this. So if they just appear like this, This is called as cephalization. Okay. And do you know something like this? Okay, I'll just change the ink over here. Okay, there's one animal with horn like this. Okay, horn like this, right? Probably the favorite of Bhaijan. Okay, so this animal, okay, antler, what we say, antler horn. So it appears like this. Okay, so I'll show you. Yeah. So normally this is, as I mentioned, this is basically your heart failure X-ray, which we already discussed, but I'm just shedding some light on that. Okay, this is the cephalization. Normally the vessels were like this, right? Vessel were like this normally. Now they are moving upwards. Okay, they're moving upwards. Okay, like this. So this is called as cephalization. Cephalus means upper one, and caudal means lower one. Okay, so cephalization is happening of the uh, arteries or vessels. Okay, pulmonary vessels. So, okay, so this is a early phase that we can say a stage one of the pulmonary hypertension. Okay, sorry, stage one of the pulmonary venous hypertension causing redistribution. Okay, so I'll just mention over here that stage one is the redistribution, and it occurs at what type of pressure? At PCWP, pulmonary capillary wedge pressure of 12 to 18 mmHg. Okay. Then stage two had the interstitial edema, right? So here, interstitial means what? This is the alveoli, this is the blood vessel, and this part is called as interstitial. So stage two will have the interstitial edema. Okay, and it occurs at what pressure? So pressure, pulmonary capillary wedge pressure of close to 18 to 25 mmHg. Okay, 18 to 25 mmHg. Okay, then we have stage three. Okay, stage three may we have the alveolar edema, in which the PCWP is more than 25 mmHg. So alveolar edema means what? Your typical batwing edema. I have a small question about the batwing edema. Do you think that batwing edema is unilateral, or I mean can it be asymmetrical, or it has to be always symmetrical? Do you know this part? Yeah. Anybody? Do you know this? So see, symmetrical means what? Symmetricals mean both side the alveolar edema can be there. Okay. But it can also be asymmetrical. That means on one side there will be more edema, and other side of the lungs there will be less edema. But it can be there. The more common is symmetrical though. Okay, that is the alveolar edema. And last stage, in stage four, you can have effusion, pleural effusion. Okay. So these are the different phases of the heart failure. So when we have the heart failure, remember in stage two, we have certain lines like this paraseptal lines. Okay, this kind of lines are there. Okay. So wherever there is a space in any X-ray, in any, I mean, in any structure in the heart, wherever there is a space, even if there is a fissure, see, this is the your fissure, okay, horizontal fissure. So in this fissure also, the fluid is getting deposited, okay. So this fluid is getting deposited into this, and this is called as fissural effusion. They have written over here pleural effusion, but I will not tell like that. Okay, this is wrong. This is a fissural effusion. Okay, this is a fissural effusion. Okay, I hope you got it. Right? So these are certain changes that you should expect in the heart failure. But apart from these curly B lines, this is called as curly B lines. There are some lines called as curly A lines also. Okay, curly A lines. These are long radiating from the hilum. Okay, so these are not very typical over here, but yes, this type of lines are there. Okay, like hilum, from hilum, these lines are there. Okay, these are nothing but your vascular lining, vascular markings. Second, it's curly B. Curly B, I told you, perpendicular to pleura. These are septal markings basically that are seen because of this, right? Then curly C is nothing but the reticular network, the diffuse. Okay, this kind of reticular network over here. Okay, it looks like this. Not here typically seen, but these are the curly C lines which occurs because of the reticular networking. But the important thing for us to know is that these are all features that you should expect. And in the second phase, second stage, you can expect the curly B lines. Okay. So you have to be skeptical whenever you see these X-rays. Okay. I've added some examples. So see here you can see. Hmm? These are the peribronchial coughing. Okay. This is how the your curly A lines or peribronchial coughings occurs. Now this is how this yellow part, you are seeing this yellow part. This is the batwing edema. Okay. And this is the cephalization of the vessel and giving rise to the antler horn sign. Okay. Antler horn sign. Okay, antler horn. Antler is just like a deer. Okay. Yep. Apart from that, you can see this airspace opacification is there because of the airspace opacification can be there because of the small alveolar edema or yeah, what we can say pleural edema. Apart from that, pleural effusion is there. Okay. And sometimes, yeah, fissural effusion. Here they have mentioned fissural effusion. Okay. So fissural effusion can also be there. Okay. I hope you are getting this. Right? So this is about the pulmonary edema signs. Now, again, same thing. I've just explained it again one more time. These are the septal lines, also called as curly B lines. Okay, curly B lines. And when do we see this? We see this when the pulmonary capillary wedge pressure is 18 to 25 in the second stage or interstitial edema wala stage, right? Then apart from that, they have enlarged heart, blunt costophrenic and costocardiac angles. Okay. So this is pleural diffusion, obviously with the pulmonary edema. Okay, and these prominent vessels are also seen in the upper part. I hope now onward you will never get confused in the X-ray. Everyone is clear about this? Okay, this is one more look of the septal lines or and this is the airspace shadowing. Airspace shadowing occurs because of the pulmonary edema, because of the alveolar or pulmonary edema, which occur in the third phase. And the PCWP is a pulmonary capillary wedge pressure is more than 25 mmHg. Okay. I hope you will be able to identify. Now identify this X-ray. What do you think? Mm. Yes. What do you think? What is this appearance called as? ARDS. Very nice. Okay. ARDS. Very good. Okay. So this is the ARDS, classic ARDS. We can say like that. Okay, see, this multiple patchy opacifications are there. This is ARDS. And how do we differentiate between ARDS and pulmonary edema? Now that's the key for discussion. Okay, so ARDS and pulmonary edema can sometimes may look them close to each other. Okay, so one thing that is clue to differentiate between these is ARDS has the normal chest, so normal heart size. Okay, you can see ARDS always has normal heart. Okay, unlike pulmonary edema, pulmonary edema has the cardiomegaly. Apart from that, vessels will be normal. Okay, vessels will be normal in ARDS. And what you see, it's about the edema. In general, the edema will be patchy. Okay, edema will be patchy in the ARDS, not the diffuse, like we have in the heart failure. It will be patchy edema. Okay, apart from that, pleural effusion is very rare in ARDS. Okay, pleural effusion because this is not the volume overload condition, right? ARDS is not the volume overload either because of the inflammation or either because of any other mechanism. There is a alveolar edema that's occurring, ARDS, okay? Right? Pleural effusion is rare. Obviously, curly B lines will not be there. Okay, curly B lines will not be there. Okay, not there, not there. So this is how you differentiate between the ARDS. Okay, in ARDS, most of the time, the actually the you can say a diagnosing criteria for the ARDS is patient should have normal PCWP or max to max PCWP should be less than 18 of Hg plus patient should have the normal LV function. Okay, normal LV function on the echo. On the echo. Okay, right. Apart from this, I think these are the important stuff about the ARDS that you should know. And that's how we differentiate between the ARDS and the PCWP. Now let's move on to the next. Yes. What do you think about this X-ray? Anybody? Would you want to diagnose it? Yes. Anybody? So this is also condition actually in the not in the heart failure though, but it can be associated with the patients of heart failure. Okay. This patient is not in the heart failure, but the findings can be seen in patients of heart failure. Very important. See, cardiomegaly is there or not? Just tell me that part. That part. Yes, cardiomegaly is there. Okay. See, okay. This and this. Just see. This is aram se. Aram se, if you take even this much, aram se, this is more than 60%. Okay. So this is cardiomegaly, right? This is cardiomegaly. But this shape of the heart is typically looking like a bag of money. Okay. Bag like this. No? Bag like this. So this is called as pericardial effusion. Okay, X-ray of the pericardial effusion. Money bag appearance. Okay, money bag appearance, right? You must have seen this type of logo, right? This dollar is usually written over there. This type of logo you must have saw. So this is how this is money bag appearance. Okay, so this is your pericardial effusion. समझ रहा है? Okay. Now, this is the same X-ray. This the same X-ray they have just shown over here. Okay. This is the enlarged globular heart, and these are the vessels basically. These are the vessels they have shown. Okay. So this is your pericardial effusion. After that, we have certain interstitial lung diseases. Okay, interstitial lung diseases. So interstitial lung diseases are essentially, these findings are seen only on the HRCT thorax, HRCT thorax or the chest X-ray, high resolution CT or this chest X-ray. Very rarely we can appreciate that, but moreover it is appreciated on the HRCT. So I have added the over here. Okay, we will just see what individual sign means. Okay. So first is reticular sign. Okay. So reticular, I'll just show you what reticular. I hope we have over here. Okay. So one second. Yeah. Okay. Yes. So here we can see one second. This. This finding usually, reticular like this. Mesh like. Okay, this is what a reticular is called. So reticular can be of two types: fine reticular and the coarse reticular. Okay, so fine reticular is very classic for the early interstitial lung disease, can also be seen in the pulmonary edema, and the late is classic for the usual interstitial pneumonia and the actual fibrosis. Okay, so this is a coarse reticular pattern. See this. Okay, this is the fine reticular. I hope you are able to appreciate this. And these are the coarse reticular pattern, right? So coarse in the sense is like this. Okay, like this. This is the coarse, and this is the fine, right? So this is how the description of this reticular signs are there. So this is also called as net or lace-like signs, and these are irregular thick lines or honeycombing. Okay, these are net-like or lace-like. Okay, lace-like, and these are they say it as a mesh, or rather than mesh, they say it as a honeycombing. Very important. Honeycombing, very classical for the usual interstitial pneumonia, which is the commonest ILD. Usual interstitial pneumonia, which is the commonest of the ILD. Okay, and this is seen in the early ILD, early pulmonary edema. Also, you can see this pulmonary edema. Okay, so these are the few things that you should know in the chest X-ray, and majority of this you can see in the CT only. The confirmation will be given by the CT only. But yes, we can see this. Apart from that, there are certain pattern like nodular pattern. Okay, fine nodular is there, solitary nodular, multiple nodular is there. Fine nodular is typical for the biliary tuberculosis. See this. Okay, this is fine nodular pattern. So whenever you are having any X-ray like this in future, don't right away jump to the diagnosis of the miliary tuberculosis. I know all of you know miliary tuberculosis. The small miliary dots are there, right? So don't jump onto the conclusion this is miliary TB, because this kind of miliary appearance is also seen in pneumoconiosis and silicosis. Okay, so you have to just say I am seeing small uniform nodules. So this is a nodular pattern of the X-ray. Most probably, you have to ask for the history. They say if they say that patient is having persistent curve, if they're mentioning that patient is having exposure to the cement industry or something like that, or either working outside, okay, in the coal mines, etc., then you can say it's an hemoconiasis or silicosis, depending on the background history. Okay, so in exams also, if you get this type of the X-ray, just look at what history they have given first. If they are mentioning that patient is not having any history of tuberculosis in the past, no history of TB in the family, he's working fine in the cement factory since last 10, 20 years, and this is the X-ray appearance. What should be the next step? You with the eyes closed, you will just select the option of AKT. But no, this is not the miliary tuberculosis. Okay, this is the silicosis. This is the fine nodular pattern which can be seen in these patients. Now let's come to the one more nodular pattern is this. This is the solitary nodule. Okay, solitary pulmonary nodule is very important. So if it is less than 3 centimeter, we don't have to worry. But if it is more than 3 centimeter, then we have to worry. Okay, then usually PET scan is done. So we have to also measure the size of the solitary pulmonary nodule. Okay, solitary means single, solo wala, solo. We say, no, I go solo. So yes, solo. It goes solo, but it can cause cancer also if the size is more than 3 centimeter. I hope you are understanding. And the third is this multiple metastasis. What this is called as? You guys know this. What this pattern is called as? Multiple masses. Yeah, cannonball type of mets, which are typical over here. Okay, cannonball mets are there, cannonball masses are there, which can be seen secondary to mostly liver cancer. Okay, etc. Right. So I hope you understood this pattern. So this pattern we already discussed lobar consolidation. This pattern is the diffuse consolidation. Okay, diffuse consolidation is there, and this is multifocal, ill-defined. Okay, multifocal, like ill-defined X-rays there, right? So this is one. This is the atelectasis. Okay, here you can see this atelectasis, small atelectasis drops are there. Here also collapse is there. Okay, this is there collapse and atelectasis, right? So these are the few important X-ray features that we should know. So again, just a quick overview, quick revision. You can say reticular is a network of linear opacities, can be fine or coarse. We know this stuff. It can be seen in IPF, asbestosis, collagen vascular disease, and ILD. Okay, done. Nodular can be seen in sarcoidosis if big nodules are there. Okay. I mean the nodules can also be fine or large. Okay, small or we can say fine or we can say big one. Okay, so the bigger one are in the sarcoidosis because of the granulomas. Miliary TB, silicosis have the fine one. Metastasis have the big one again. Similarly, reticulonodular, I mean, these two pattern together can also be seen in sarcoidosis and lymphangitic carcinomatosis. Then GGOs are very typical for the NSIP, okay, non-specific interstitial pneumonia, okay, and also hypersensitivity pneumonitis. GGOs means what? These are hazy, increased opacities without obscuring vessels, okay. So this is also very important. In COVID, you might have seen that, okay. If I have to just give example of the GGOs to you, you can say Gigios appear like this only. Okay. Gigios will appear like this only, but little bigger one in size like this. Okay. The whitish, little whitish. Okay. Little whitish like this. Ground glass opacity is like this. Okay. In the COVID or mostly in the CT, it will be better appreciated. Okay. Sorry for. Yeah. Then apart from that, we have consolidative alveolar pattern. We know it can be seen in the cryptogenic organizing pneumonia, COP, acute hypersensitive pneumonitis, and the alveolar sarcoidosis. Okay, consolidative like pattern, consolidation like pattern. And lastly, honeycombing. Honeycombing means coarse reticular pattern. Okay, honeycomb like pattern. So this will be classical for the interstitial pulmonary fibrosis or usual interstitial pneumonia. Okay, so please remember all these patterns are very, very important for us to. Okay, this is about the important ILDs. Apart from that, we already discussed miliary there, cystic can be there some patients, and volume loss can also be there in the IPF and the early stage ILD patients. Okay, so they have given the classification over here. See, ILD is classified on the basis of radiological finding into first is idiopathic interstitial pneumonia, in which we have UIP, that is interstitial pulmonary fibrosis, also called as usual interstitial pneumonia. Okay, and the finding in each of them is actually one MCQ if you are preparing for an exam. So usual interstitial pneumonia, honeycombing will be there. NSIP has a ground glass and fine reticular pattern. I've already described to you that what does ground glass mean, what is fine reticular means. That is NSIP. Then COP, that is cryptogenic organizing pneumonia. Here, patchy and migratory consolidation will be there. AIP, ARDS-like pattern, diffuse alveolar pattern will be there. Diffuse ground glass opacities. Okay. Then RBILD, DIP, so ground glass central lobular nodules. It is top typically in the smokers. Okay. And lastly, LIP. So these are the different types of the ILDs. Right, apart from the granulomatosis, we'll have the sarcoidosis and the bilateral hilar lymphadenopathy, reticuloendothelial and the perilymphatic nodules. Okay, and then we have different types like silicosis, cold-worker pneumoconiasis, asbestosis, and drug-induced like amidoiron, bleomycin, methotrexate. Okay, so these are all connections. These are all subtypes of the ILD. Okay, these are all subtypes of the ILD that you have to read. Right. Now, so this is a small examples you can just remember, which is normally asked in the exam. Just go through that, right? So this is in general the revision of all the chest X-ray we saw till now. First is atelectasis, okay, here, right? Then this is cardiomegaly, okay? Then consolidation, right? Edema, pulmonary edema, okay? This type of serious battening edema is there in this patient. Here the effusion is there. Okay, I don't know where effusion is there or this X-ray are little problematic. I think so. But anyways, emphysema, fibrosis, this is hernia, infiltration, mass, then nodule. Okay, these X-rays are actually I'm not seeing any finding related to that. Okay, anyways, we can just skip this slide. Okay, right. Now let's start with something interesting, the abdominal X-rays. Okay, abdominal X-rays, very, very important for us to know. I hope till now you're confident enough about whatever things we discussed. Okay. Are you? Yes. Did you understand? Okay. Before going to abdominal, we have a small X-ray left, one leg X-ray left. So we'll just have a look on that. Yeah. Okay. Before going to abdomen, one small X-ray is left. So let's see this one. Right. So we can see normally this gap should not be there. Okay. In between the cardiac shadow. Right? You can see there's some air that is lying over here. Okay. Some air is lying over here in between this. Okay. This is nothing but called as pneumomediastinum. Okay. That means air in the mediastinum, which is not normal. Okay. And this pneumomediastinum can eventually give rise to pneumothorax also. Okay. In certain condition, this pneumomediastinum can be seen. Okay, like if patient is having, so it can be of two types. First is spontaneous, if patient is having acute asthma attack or Valsalva aneurysm. Okay, it usually happens because of the alveolar rupture. Okay, I'll just write over here. It can be of two types or three types, let's say. Spontaneous, traumatic, and extension from the other side. Okay, so spontaneous, right? So spontaneous means unknowingly it has happened because of the increase in the intra-alveolar pressure. Okay. Increase in the intra-alveoli means this alveoli in the lungs. Okay. So sometimes this alveoli ruptures and this ruptured alveoli can leak the air into some part of the lung. Okay. So intra-alveolar, you can say intra-alveolar pressure is rising and that can lead to this rupture and this bronchovascular sheath. Okay, so this broncho and vessels, okay, and there is a sheath over here between the bronchus means air and here is the air blood and between this sheath is there. So what happens? This sheath collects all the air like this in the black, right? Okay, and that gives rise to this appearance. Okay, so this air gets into the bronchovascular sheath, right? and that gives rise to this type of pneumomediastinum. What are the actual causes? So in causes, first of all, acute asthma attack. Okay, acute asthma attack, the Valsalva maneuvers. Okay, forceful, forceful breathing, Valsalva, right? Apart from that, drug use, cocaine, marijuana, even diabetic ketoacidosis sometimes. Okay, drugs. So all these are spontaneous causes. Whenever forceful inspiration, etc., is there, that can lead to this. So first is spontaneous. Second is traumatic. Traumatic means either if there is a chest trauma, somebody had a blow on your chest, borrowed trauma, okay, during the mechanical ventilation, endoscopy, esophageal perforation. So in all these cases also this can happen. Okay, I'll just change the ink. Okay, chest trauma, then endoscopy. Okay, or Boer-Hove syndrome. Do you know Boer-Hove syndrome? Boer-Hove means what? The vomiting against the closed glottis, right? Boer-Hove syndrome. Alcoholic patient usually have this. So that is basically your esophageal perforation. Okay, esophageal perforation, right? Esophageal perforation. And apart from that, the borrowed trauma in the mechanical ventilation. Borrowed trauma in mechanical ventilated patients. Okay. This is spontaneous, this is traumatic, and we have one more that's an extension from the other sides. So either a pneumothorax or from the retroperitoneum. Okay, so first is pneumothorax. That means already the pneumothorax has happened and that has led to this pneumomediastinum. And second is perforated bowel perforation. Okay, perforated bowel. That can also lead to this. Okay, that can also lead to this perforated bowel. Okay, leading to pneumomediastinum. Right? So patient in this case can have acute chest pain, right? Dyspnea, all these features will be there. And two important features are there. First is called as subcutaneous emphysema. That is crepitus in the neck you will feel. Okay. That is subcutaneous emphysema. And second is a crunching, rasping sound synchronous to the breathing of the patient in the lateral position. Okay. So these two signs are called as, I'll just write over here. Okay, two signs are there. First is your subcutaneous emphysema. Okay, subcutaneous emphysema that gives rise to mostly in the neck. Okay, bubble-like sound is there in the neck. Apart from that, there is one more cell called as Hammam's crunch sign. Okay, Hammam's crunch or Hammam's sign. It's basically a crunching, rasping sound with each heartbeat. Like okay, but like you when we press the some chips packet, right? Sometimes we press the chips packet. That sound comes. Okay, that kind of sounds, but in a obviously less harsh quality that will be there, and because of this air that is accumulated. Okay, okay. So this is a crunching sound, crunching and rasping sound synchronous to breathless. Sorry, heartbeat. Rasping sound synchronous to heartbeat. Okay, so this is classical for the pneumomediastinum. And apart from this, there are other findings also that can be sometimes seen. Okay, so these are not the X-ray findings. These are the clinical findings, right? These are the clinical findings. But what X-ray findings will be seen? So X-ray findings are typical in this patient. So first is called as continuous diaphragm sign. Continuous diaphragm means what happens? The cardiac shadow where the heart is there. Now that sellout is lost because of the mediastinum. I hope we have that over here. Okay. Yeah, you can say, you can see like this. So mediastinum, the cardiac shadow, the diaphragm appears complete like this. Okay. Complete like this. And the heart shadow will appear like this. Okay. So normally because of this heart cardiac shadow, diaphragm won't be able, we won't be able to see this, right? So the first sign that will be there is in this patient is the continuous diaphragm sign. Okay. Continuous diaphragm sign. Okay, that will be first. Apart from that, you will also see uh, air tracking along the hard borders and great vessels like this. See, this is the gas that outlines the surface of the mediastinal area. You can see this. Okay, just a second. I'll just make it in the white. You can see this, right? This one. Okay, right? This. Huh? So this line that you are seeing over here, okay, is also one more clinical sign that is called as air tracking along the heart borders and great vessels. Okay, so that will be the second. I'll just improve my handwriting a bit so that you should feel like to read that, right? Hmm. First is continuous diaphragm sign. Second is air tracking sign. Okay, I explained both the sign to you, right? Third, third is called as a ring around the artery sign. Okay, here the air is seen around the pulmonary artery. I don't know if you have it over here. Okay, it's not over there, but anyways, we'll just explain it. Okay, then fourth is called as spinnaker cell sign. Okay, here we have this. So spinnaker cell is like this. Okay, you must have seen in the cartoon or in the movies also, right? This kind of cell is there. That means with the help of the air, the boat gives or the a small boat goes further, right? Because of the air with the air force, right? So this is called as spinnaker sign, spinnaker wing sign. So here we can see this appears like this. Okay, that gives that kind of appearance. See here, they have mentioned over here. Okay, apart from that, the here also you can see that. So that's look like a spinnaker sign. Okay, this is also classical for the this type of edema. Sorry, not edema, the pneumomediastinum. Okay, so it has continuous diaphragm sign and the spinnaker cell sign. It is typically seen in the neonatal posterior-anterior X-ray when the thymic lobes are displayed laterally by the air. Okay, these are the thymic lobes that are replaced laterally because of this air. Okay, this is called as spinnaker cell sign, and here we can see the continuous diaphragm sign also. Right, like I mentioned, the diaphragm is separated. You know, this is called as continuous diaphragm sign of the pneumomediastinum. Why the pneumomediastinum occurs? Yes, we know it occurs because of three causes, right? Spontaneous causes are there, traumatic causes are there, and then extension causes are there, right? I hope you know this now. Okay, so that's all about the pneumomediastinum. Now let's quickly see the mediastinum. Like what are the anterior mediastinum tumors, or what are the X-ray changes we can see in the anterior mediastinum, middle mediastinum, and the posterior mediastinum. Okay, so this is the anterior part of the mediastinum. Okay, anterior, this is the middle, and this is the posterior part of the mediastinum. Okay, so in anterior, what structure we have? Right, in anterior, obviously in front of the mediastinum, they say. In anterior, we have the, here we can see, just like, okay, in anterior, we have the heart, thymus, and retrosternal thyroid. Okay, heart is there, thymus is there, and retrosternal part of the thyroid is there. In middle, we have trachea, esophagus, and the lymph node, and the posterior is mostly spinal cord. The spinal element is there. Okay, neural component is there. It's very easy to understand also, right? In the middle part, the safe part will be for esophagus, the airways. The anterior part, obviously the heart should have been in the middle, but heart is little anterior in the human structure. Okay, but it is protected by the rib cage, so we don't have to worry much. Thymus is there and retrosternal thyroid is there. Many people might feel that heart is in the middle, but no, heart is in the anterior mediastinum. Now, anything happens to these three, you will see the changes in that part of the mediastinum. If thymoma is there, it will be seen in the anterior mediastinum. Okay, which is the commonest cancer also. Okay, commonest tumor also of the mediastinum. Let's see now. So the best is investigation is CECT. For posterior, the best is MRI. Okay, initially is obviously chest X-ray for the mediastinum imaging, right? So common lesions, most common lesions, overall mediastinal mass is thymoma, anterior mediastinum, thymoma, middle mediastinum, lymph node masses, because lymph node is also there. Middle in children, okay, middle mediastinum children is the most common is foregut duplication cyst, also called as bronchogenic cyst, and the posterior mediastinum is neurogenic tumors like neurofibroma and schwannoma, right? I hope you are understanding this. Yes. So now let's see the anterior mediastinum. So thymoma is there, teratoma is there, thyroid lesions is there, and terrible lymphoma is there. Okay, so four T's of the anterior mediastinum. Okay, this kind of thymoma is there. Okay, then teratoma, thyroid lesion, and the terrible lymphoma. Thyroid thymoma is overall most common mediastinal tumor. Okay, it is associated with the myasthenia gravis, where the treatment is removal of the thymus. Okay, and obviously for confirmation we do CT scan, and we have to check for if there is a necrosis or cyst suggestive of thymic carcinoma. Okay, so we are seeing anterior mediastinum. Now let's see the next one. Okay, in the anterior mediastinum, you can see this sign called as hilum overlay sign. Okay, here we can see this is the artery, this is the pulmonary artery, but because of the tumor, this hilum is overlay on the tumor. Okay, called as the hilum overlay sign, which is again seen in the thymoma. Okay, and in the anterior mediastinum, you can see this. Then the middle mediastinum, as I mentioned, in the adult, we have the lymph node masses, and in the children, we have the foregut duplication cyst. In the posterior mediastinum, as I mentioned, nerve roots are there. So neural tumor or neurogenic tumors is the most common cause, right? Like schwannoma, neurofibroma, all will be there. Okay, right. So this here you can see this type of mass is there, right? This mass is there. Okay, which is actually compressing the spinal cord also. Okay, so here the spinal cord mass is there, and because of this, the posterior part of the spinal process, etc., is gone. Okay, right. So this is the about the neurofibroma, right? Neurogenic tumor. Neurogenic tumor extending into neural foramen of the spinal canal and causing the widening of the foramen. MRI is the preferred. Okay, and this can give rise to the dumbbell tumor. That is spinal cord plus neural foramen widening. Okay, this kind of dumbbell tumor is there. Okay, like this. A big dumbbells shaped tumor is there. So this is called as dumbbell tumor of the posterior mediastinum. That's it. That's it for this. Now let's start the important part of X-ray. Okay, just tell me. Okay, this is the colon shadow. This is the gastric shadow. What do you see? Voice is clear now or no? Voice is not clear? Clear or no? Yeah, yeah. Actually, I had turned off the mic, no? That's why my voice and all must have gone. Okay, tell me. Don't, no clues? So this is a normal abdominal X-ray. Okay, exactly. Normal sets of gas. This is the normal X-ray of the abdomen. This will how it looks. Okay, so I will explain now all the features what we see in the normal X-rays. Okay, very very important for us to remember. Hmm? Right. So see, this is liver. This is the spleen. Okay. Okay. Right. So this is the liver. This is the spleen. Okay. This was the left kidney, right kidney. Okay. Not this one here. Okay. This overlaying. Okay, posteriorly, kidneys are quite posterior. Okay, this is the normal bowel gas. Okay, so this is the normal abdominal X-ray. So now whenever you have the abdomen, no, always look for different organs in the abdomen. First is, what does stomach say? Okay, first is, what does stomach say? Stomach will have the fundic shadow. Okay. Then what about the small intestine? Small intestine has something called as a volvula convenientis. Okay, volvula convenientis. So this volvula convenientis is something which is across the loop like this. Okay, so it's not clear over here, but though I can just tell you like this. So first is stomach. Stomach will have the gas, easy to understand. Small bowel or small intestine will have something called as volvuli Conniventis. Okay, conniventis. So what does that mean? That means the line, continuous lines will be like this. Okay, in the small intestine. And large intestine will have this something called as hostration. Okay, hostration. So hostration is nothing but the markings will be there. Hospital markings will be there, and they do not cross the full width. Okay, so they will be like this. Okay, so just a second. They will be like this. Okay, like this. This will be like hostration. So I will just show you the images now. Okay, so these are some features of the each part of the normal X-ray. Okay, so as I mentioned, stomach will have the it is present in the left upper quadrant. We all know that, and it will have the round or oval lucency. Okay, under the hemidiaphragm. Okay, which we call as a shadow of the stomach. And small bowel will have something called as volvuli conniventis. Okay, thin lines crossing the lumen may be faint. Then large vowel, as I mentioned, we have the hostile markings. They do not cross the full width. Okay. Then coming to the rectum, rectum will have the gas shadow in the pelvis like this. Okay. This is the rectal shadow. Okay. This is the rectal shadow. This is the gas shadow by the rectum. Liver, as I mentioned, occupies in the right hypochondrium. Spleen occupies the left hypochondrium. Kidney is not always visible. Very important. Okay. Psoas muscle seen in the symmetrical soft tissue shadows with the from the lumbar to pelvis. Okay. Here. Okay. Then bladder, seen in filled with the urine. Okay, so usually whenever we do the X-ray, we ask the patient to empty the bladder. Then bones like spines, ribs, pelvis, hips. Okay, diaphragm, normal dome, we can say calcification. Normally absent, and if present, then we can suspect the kidney stone, etc., ureteric stone on the basis of that. Okay, so now let's see interesting topic of discussion. We have the X-ray. So in X-ray of the abdomen, we have three main pathologies. Okay, first is obstruction. So in obstructions, we have small bowel obstruction, large bowel obstruction is there. Okay, and the paralytic ileus is there. So obviously, when the small bowel obstruction will be there, the bowel loop, which are dilated, will have what? Okay, just imagine if small bowel obstruction is there, small bowel obstruction is there. That means the food particle that is going is still only small bowel. Apart from that, the large bowel is there. Okay. So this is the large bowel. Let's say this is the rectum, but till here the fluid has gone. So what happens if this is the obstruction? The part prior to that obstruction becomes big in size. Okay, becomes big in size. So the part that is enlarged, that is dilated, will have volvular conventis. Okay, that will have one volvular conventis, and we have to look for that part. And if the distance and the loop size should be more than 3 centimeter, normally it is 3 centimeter. Okay. Similarly, in large bowel obstruction, so along with that, you will have the in small bowel obstruction, you will have step ladder air fluid levels will be there, and string of pearl signs will be there. In large bowel obstruction, the bowel loop will be bigger in size. Obviously, colon and cecum is bigger in size. Colon is 6 centimeter, cecum is 9 centimeter. Okay, so that distance will be there. Along with that, hostile markings will be there, right? You know hostile markings. What are those? So these are incontinuous markings, basically you can say. Apart from that, we can have coffee bean sign, and we have the kidney shaped loop in the cecal volvulus. Okay, so I have explained everything. Now you will answer. Okay, right. Then paralytic ileus will have both gas in both small bowel and large bowel, including rectum. Why? Because there is no particular obstruction over here. The obstruction, I mean, the bowel whole as a whole is affected. Complete bowel is affected in the paralytic ileus. Got it? So that's why we can't label the paralytic ileus also into it. Okay. So now let's see the X-rays. I want you to answer this. What do you think? Just comment quickly. This is very easy. I've explained everything before going into the discussion itself. Which bowel shadow? So just look at this distance. It's obviously more than 3 centimeter. Okay. So when you check the X-ray in your hand, it will be obviously you have to measure with the scale, and it is more than 3 centimeters. So what do you think? And what these lines are? What these right lines are? Don't do this to me, guys. Please answer. Am I not audible to all of you? Just tell me where is the obstruction? Small bowel, large bowel obstruction, where it is. Exactly, very easy, very simple for you. Okay, now you know this is the small bowel obstruction. Very nice. Okay, can everybody tell me what is the most common cause of small bowel obstruction? Very nice. Okay. So because of this, these are continuous, right? These lines are continuous. Okay. These lines are continuous over here, isn't it? I'll just draw in a white. Okay. So see, these lines are continuous over here. Okay. Even here, right? These lines are continuous. These are called as volvula conniventis. And yes, somebody mentioned, very nice, Kumar. This is the most common cause for this is adhesion. Okay, so adhesion is the most common. Then hernia can be there, Crohn's stricture, tumor, intussusception can be there, but adhesion is there most commonly. Okay, adhesion can happen after surgery, after procedure, that can happen. Okay, very important. Please remember this. Apart from that, this patient has, because of this obstruction, small bowel obstruction, in any bowel obstruction, there will be typical type of pain is there. Can you name that pain? What type of pain is there in any form of obstruction? Okay, adhesion can be there, Crohn's structure can be there. Okay, anything can be there. Exactly, colicky type of pain. Very nice. Colicky pain will be there. Okay, sharp pain, like obstructing pain. This kind of pain will also be seen in the your erector calculus. Okay, very important. Whenever there is some obstruction, colicky pain will occur. Very important. And how do we manage this patient? In any obstruction, always remember, in any obstruction, first make the patient NPO. Okay, and in particular for the small bowel obstruction, we do the nasogastric decompression of the fluids because this bowel is stretched and because of this patient is having pain. So if you do nasogastric decompression, the patient will have good effects. But always remember to do, if patient is having strangulated bowel, and that means the bowel is dying and patient is not feeling well at all. Its markers, this vitals are going down. Also, if you do the angiography, sometimes we should do angiography in this patient also if you're suspecting mesenteric ischemia, anything like this. Okay, but if it is like that, strangulated bowel is there. So this, most of the times, this patient also need the exploration, surgical exploration. So based on that, laparoscopy, what we say. So based on that, the surgeon decides. So if it is strangulated, then surgery is recommended. Okay. If severe abdomen is there, okay, surgery is recommended. Right. Now coming, so these are the findings that we just saw. Dilated bowel is there and volvular conniventis was there. Okay. So just like that. Now let's move to this one. Yeah. So again, this is the same. You can see small bowel dilated over here, right? Small bowel is dilated over here. And this is what your volvular conniventis is there. Okay. Volvular conniventis is there, right? So now you will never have a doubt about the small bowel obstruction versus large bowel obstruction. Why it is important for us to differentiate is, see, small bowel obstruction is common. Okay. Small bowel obstruction is common, but large bowel obstruction can be very serious also. Okay, so for large bowel obstruction, the resection, even the divergent surgeries can be recommended, or endoscopy also might be needed. So better to work little faster. So better to differentiate between two. Whereas when we talk about the paralytic ileus, so in paralytic ileus, as I mentioned, the both valvular conniventis will be there, hostrations will be there, but a rectal shadow will be there because the whole bowel is affected. Okay, so I hope I'm able to help you to differentiate. Now I will show you one more X-ray. So then you identify this. Okay, this is also the same. Dilated transverse colon is there. Okay, this is the sigmoid. So this is actually around, this is the X-ray of the large bowel obstruction. Okay, large bowel obstruction. Okay, this is the X-ray of large bowel obstruction. They've already given the findings over here. But yes, you already know because the hostrations are there, hostra are there. Okay, so this kind of hostra are there, right? These are the hostra, right? We can say these are the hostra, not very complete. Okay, not very complete. See, this is this much only. Okay, here also this much only. Okay, so these are dilated transverse colon. Okay, and dilated sigmoid colon. Okay, level of obstruction is there. Here is the level of obstruction. Okay, so this is again the large bowel obstruction. Similarly, you can see this gas-filled colon is there. So this kind of ostration are there. Okay, this kind of ostration are there. Here also you can see this kind of ostration, right? These are ostrations, ostrom. Okay, so you can have a clue. See here also you can see clearly. Okay, so these are nothing but a gas-filled colon. Loops of small bowel are normal over here, and this is the gas in the rectum also. Okay, this there is a gas in the rectum, right? So what do you think this would be? The small bowel are we able to see? These are the small bowel loops. I'm not able to appreciate though the valvular conjunctivis over here, but this will be more over the paralytic. Okay, because the rectal shadow is also there, no? So paralytic ileus is also there. Okay, exactly. Okay. Now, what about this one? Yeah. What about this one? This is also one of the bowel obstruction. Okay, we can call it as a closed bowel obstruction. Okay, very important. Yes, you guys know this. गली का बच्चा बच्चा जानता है इसे. Exactly. This is a coffee bean. Okay, this is a coffee bean. See over here. Okay, this is a sigmoid volvulus. Okay, like this. Okay, coffee bean like appearance over here. See over here. The dilated bowel loops are there, right? Dilated bowel loops are there, right? And you can see this type of structure is there. Okay, and urinary catheter is also there here. This is the urinary catheter. Okay, this is the head of that, the radiolucent head, right? So this is the. Now what about this? What about this one? Yeah, very good, very good. This is the cecal volvulus. Okay, this is the cecal volvulus. This is the kidney-shaped volvulus, right? This is the kidney-shaped mass. When we were discussing over there, I explained you already over there. Okay, so this is the cecal volvulus. Very nice. Okay, cecal volvulus. Okay, where the kidney-shaped size is there. Okay, kidney-shaped is there. So the cecum is grossly dilated in cecal volvulus more than 10 centimeter. Okay. And when we do the contrast enema in this case, we get the bird beak appearance. Okay. On contrast enema, we get the bird beak appearance. Bird beak like this. Okay, like this. So obviously here we can't see that. It is the CT, the contrast finding. The bird beak appearance will be seen in the cecal volvulus. Please remember. Okay, but important for us to remember at least X-ray that we should understand that this is how the cecal volvulus appears and this is how the sigmoid volvulus appears. Sigmoid volvulus have the coffee bean appearance and cecal volvulus are the this type of kidney bean type of appearance. Okay, and how do we manage these patients? So cecal volvulus usually need IV resuscitation. Obviously, definitive is most of the time decompression, but it is rarely successful. Endoscopic decompression is rarely successful, so we manage with the surgery. Okay, so most of the times we do the right hemicolectomy. It's a surgical thing, but as a physician or as any person, you should be able to know this. Okay, hemicolectomy will be there. Okay, so this is about the cecal volvulus. Now let's come to the very important discussion, that is perforation. Okay, intestinal perforation. Right. This is also the coffee bean appearance of the dilated cecum, same thing that is given over there. Okay. Now, what do you think about this X-ray? Anybody? Anybody, what do you think? What do you call this as? Yeah, look at this beautiful X-ray. It's very, very nice, Harshal. Very nice. This is right air under diaphragm. Diagnosis is perforation. Very clear for us to do, right? Perforation of the bowel. Perforation of the bowel, and the air has now passed from the just below the diaphragm like this. Okay, air under diaphragm. So this is a sign of bowel perforation. Very important sign. Okay, so let's see certain signs for the bowel perforation. That what else we can see. Okay, so whenever you have the bowel perforation, best view will be the erect chest X-ray view. Okay, just to look for all this fine. Okay, erect chest X-ray is done. Okay, for the bowel perforation, when you are suspecting that, even supine abdomen X-ray, erect abdomen X-ray is also good for us. Okay, standing. What are the classic X-ray signs? First is free air under diaphragm and the continuous diaphragm sign. Okay, like this only, continuous diaphragm sign. Okay. So the X-ray features. So X-ray features are divided into two parts. One second. Okay, X-ray features are divided into two forms. First is called as free intraperitoneal air. Second is specific name sign. In specific, we have different signs then. Okay, first is free intraperitoneal air. Okay, these are the just named sign. Okay, I'm just classifying it for our benefit. Free intraperitoneal. So you understand now. This is inside the peritoneum. Okay. So first is your air under diaphragm. Okay. I'll just label A, and this is first air under diaphragm, and second is continuous diaphragm. Okay, continuous diaphragm. Right? Inner diaphragm and continuous diaphragm. So inner diaphragm is just like that. Continuous diaphragm is continuous. That is the first one. Second is specific sign. Okay. Second category, B category, is the specific sign. In specific, we have different name signs. Okay. Out of that, the first one is regular sign. Okay. Regular sign. Very, very classic. Very, very classic. Okay. It is classic for the pneumoperitoneum. What happens here? You have to see, this is also called as double bowel sign, double wall sign. So here, the both sides of the bowel wall are visible. Okay. I'll just show you that one second. Hmm. So this is also again the free, I guess that's the same thing. So regular sign means what? It's also called as double wall sign. Okay, double wall sign. That means both the sides of bowel wall will be visible. Here inside the lumen and the outside of the lumen both will be visible. Okay. Lumen and outside visible. Okay. Then one more sign is there. It's called as football sign. Football sign or cupola. Football sign is there. Okay. So here also large oval lucency is there outside the whole abdomen. Looks like a football. Okay. Then third is cupola sign. Cupola sign is also same. Air under, basically air in the diaphragm. Okay. Below diaphragm, the big air balloon like thing. Okay. So let's see now this one. Okay. So here, this is the free gas. This is the free gas. This is the, because of this transverse column, this is looking like a continuous diaphragm sign. Okay. So this is also the perforation. Now this one, and look at this. Okay. Here you can see both the lumen of the wall. Okay. Both the lumen of the wall is seen. Inside and the outside air can be seen. Okay. So this is your regular sign. Okay. So here we can see. Okay. Inside and outside, both sides are visibly, right? Okay. Like this. Both sides of the bowel wall are visible. Okay. Like fluorescent, what we see. Okay. Unlike here, not clearly visible, right? But here it is clearly visible. Okay. This is actually the same thing. Sorry. This is actually the same thing. Okay. Here also we can see we have just, negated the image a bit. This is the same thing, but unlike this over here. Okay. Or here. Right. Yeah. Okay, so this is the regular sign where the both sides of bowel wall are seen because of the air outside the diaphragm and air inside the outside the diaphragm. No, sorry, air outside the bowel lumen and air inside the bowel lumen. Okay, similarly, see here also you can see both the side of the vessels. Sorry, both the side of this lumen. Okay, air, air. Okay, like this. Okay, so this is how it is, right? This is the air. This is the double lumen. We can see dilated small vowel is there, and this is your again regular sign. Okay. Now, see over here. Air under diaphragm is there. Air under diaphragm is there, and dilated small bowel lumen is there. Right? Small bowel lumen is dilated over here. So this is also one of the finding of the your pneumoperitoneum. Okay. Similarly, here also you can see any ideas that what could be this? I will just give you a clue. This is a patient of IBD. This is a patient of IBD, inflammatory bowel disease. So now we are over with the pneumoperitoneum. We are starting with the new miscellaneous few abdominal ECGs that you should know. What do you think? See, this is colon basically, and the size of the colon is more than 12 centimeter. More than 12 centimeter almost. What this is called as, it's toxic. Yeah, you can say it's a megacolon or toxic megacolon. Okay, very classic. Okay, for the ulcerative colitis. Okay, EOC, ulcerative colitis, very classic. Okay, so apart from this, there are different ulcerative colitis features. that can be seen. Okay, like thumb-like feature is there. Okay, loss of hostration is there, mucosal thickening. So loss of hostration is also there. In this patient, the hostra are lost. Okay, so toxic megacolon will have obviously the enlarged side of the colon will be there, but the loss of hostra will be there. Okay, loss of hostration, then mucosal thickening will be there. Okay, mucosal thickening, right? Then narrowed and shortened colon due to fibrosis, narrowed and shortened colon. Okay. Okay. So that will be there. Apart from that, when you do the color contrast imaging, barium enema, basically what we do for the ulcerative colitis, collar button ulcer, lead pipe like appearance, right? You must have seen that lead pipe wall appearance. Images may like this exactly, and whole it will be filled of this lead pipe of like appearance. Okay. So filled, obviously the white color. Okay, obviously with the white color. I'll just use the white over here. Okay, like this. Okay, this kind of lead pipe appearance is there. Okay, in the barium enema. Okay, so this is exactly the appearance what we can get in the patients of ulcerative colitis if we do the contrast imaging. Okay, yes, right. I hope you got it. Okay, then this is the same description that they have given. Megacolon, mucosal islands are there. Okay, few last images here. Look at this. What is this condition? See, there is a air shadow over here. Okay, we rarely actually see this kind of X-ray, but if you are attending this class, I want to be, actually sure about this topic also. See, first of all, what is this? This is the diaphragm shadow. Okay, obviously, and this will be your liver shadow also. Okay, this is the, you can see biliary tract. Okay, biliary tract. Okay, biliary tract, gallbladder. This is how the liver is, right? This is the liver basically, and this is how the your gallbladder duct is there, right? Cystic duct, what we say. This is where the gallbladder is also there, and this is where the pancreas is there. They go into the pancreas like this. Okay, so here we can see this air is there in the biliary tree, right? So there is air in the biliary tree, which can happen after surgery, after procedure. Okay, so that's what we can see over here. Okay, so this is the liver. This is the biliary gas that can be seen. And this is the biliary stent. After the procedure, it can be seen. Okay, so these are all important X-rays. We have few over here, last one or two. So then we have this X-ray. Just look at this X-ray. What do you think? Just tell me. Okay, and just look at this X-ray over here. Look at the bones. Bone resorption is there, right? Osteoclastic lesions are there. Similarly, over here is also the same thing. Here is also the same thing happening. Okay. So these are sclerotic bone lesions. Okay, these are sclerotic bone lesions. Okay, very classic for the malignancies. Okay, secondaries. Right. These are the all sclerotic lesions. Exactly, the red one is the sclerosed part, normal part, you can say. Okay, so that's it. Pneumobidia, maybe I already discussed. Lung malignancies and all are there, which is not like much a common aspect, but we have to see the this congenital heart disease. We'll just quickly go through that. We'll know about the pattern and all. I'll just quickly revise that for you. Okay. First is tetralogy of Fallot. This is the boot-shaped heart that is seen in the tetralogy of Fallot, right? Tetralogy of Fallot means what four factors are there. Okay. Or okay. So pulmonary stenosis there, VSD is there, overriding of the aorta, and the RV hypertrophy is there. Okay. Overriding of the aorta, RV hypertrophy, pulmonary stenosis, and the VSD. Okay, tetralogy of the palace because of the RBH. Okay, yes. Then this is how the transposition of the great arteries will look. Okay, so great arteries are transposed. Pulmonary artery comes from the uh, right side or left side, and the left ventricle, I mean. Okay, and from the right side, the aorta will come. Okay, so this is the transposition of the great arteries. Anatomical changes that can occur because of that gives rise to this appearance. Okay, so this is called as egg on the string appearance. Okay, this looks like egg, and this is the string. Okay, egg and the string. Okay, so egg on the string appearance. Okay, this one now. Snowman appearance. Okay, or figure of eight appearance. which can be seen in case of total anomalous pulmonary venous return, TAPVR. Okay, where all pulmonary veins drain abnormally into the systemic veins in this disease. Okay, TAPVR, snowman sign. So they have given the pathology and all around that. And then we have coarctation of aorta. Okay, so aortic coarctation is there. Okay, and then Epstein anomaly is there. So Epstein anomaly means atrialization of the right ventricle. Okay, so normally this happens basically. RA-RB becomes 1. Okay, that is the atrialization of the right ventricle, giving rise to this kind of big heart. Okay, also called as box-shaped heart. Okay, box-shaped heart is seen in the Epstein anomaly. Right, so here is that. Okay, then yeah, then we have certain acquired heart defects like mitral stenosis. So in mitral stenosis, what happens? This border becomes 1. Okay, this border becomes 1. Okay, so this is called as MS. It's very typical for the MS. The left heart side, what we can saw, line becomes straight because of the RA enlargement. Sorry, LA enlargement. Okay, LA enlargement occurs in the mitral stenosis, and because of this, there is a straight line kind of appearance that occurs. Yes. Right. In mogul sign, there is one mogul sign also over there. Okay, where all this first mogul is basically aortic knuckle, second mogul is main pulmonary artery, third mogul is left arterial appendage, and fourth mogul is apex. So these all come in the straight sign, also called as mogul sign or straight heart border sign. Okay, or straight left heart border sign. All right. Yeah. Okay. So that's all about the X-rays, the abdominal X-rays, and the chest X-rays. In the next class, we will discuss about the CTs and MRIs in a nutshell. Okay, all the important pathology. Only one class is left now. Probably we'll try to take it tomorrow. Okay, so I hope you understood majority of. Okay, any if there's anything you want or any suggestions, uh, please let me know. Yeah, PET CT also we'll try to cover in a small aspect. Okay, PET CT is not much big of the topic, but yeah, we'll cover that. Okay.